There will be for sure some repetition, of course, with the previous talk, but that I hope will help for the discussion and to clarify better the ideas of each one of us. I think that there are basically three clinical scenarios for tricuspid regurgitation. One is the isolated primary or organic tricuspid regurgitation. The second scenario is the secondary or functional tricuspid regurgitation in patients undergoing left-sided valve surgery. And the third scenario is the so-called futile, that was defined futile, late tricuspid regurgitation following left-side valve surgery. I'm not going to spend much time on isolated primary organic tricuspid regurgitation. I think that the talk of Pedro before was quite exhaustive on this particular subject. Of course, there are different causes of primary or organic tricuspid regurgitation. Can be rheumatic disease of the tricuspid valve, can be an endocarditis, can be trauma, can be a carcinoid disease, myxomatous degeneration, giving a prolapse specifically on the tricuspid valve. And there are many congenital anomalies, particularly the Epstein anomaly that was discussed in the previous talk. I think the type of surgery has to be really very much tailored to the individual situation. Quite often for endocarditis it's also necessary to replace the valve. For traumatic tricuspid regurgitation, in our experience, the edge-to-edge concept has been very, very useful. For the carcinoid disease, most of the time is replacement of the valve. For prolapse due to myxomatous degeneration, the edge-to-edge concept again can be very useful. And for congenital anomalies, we have seen before now the corner operation for the Epstein anomalies really seems to be the best option in these particular patients. I want to make the point that in the guidelines there has been a kind of aggressiveness toward tricuspid regurgitation. Of course, is class 1 recommendation when we have a symptomatic patient with isolated primary tricuspid regurgitation. But also we added in the guidelines that even in asymptomatic patients or mildly symptomatic patient with severe isolated primary tricuspid regurgitation, if we have a progressive right ventricular dilatation or deterioration of the function, surgery is recommended, and this is a recommendation class 2A. Now let's go to the second scenario, secondary or functional tricuspid regurgitation in patient undergoing left side valve surgery. This was the subject of Roberta Dion, the first talk of this session. Very typical feature is this asymmetric annular dilatation. And this is a very, very old slide, but already at that time was very well understood that the dilatation was not at the septal leaflet, but at the posterior and anterior leaflet. In addition, a very important feature of functional tricuspid regurgitation in this context is leaflet tethering. And you can see here leaflet tethering, which is revealed by this variable, the coaptation depth, which is a very important variable, reflecting the severity of the tethering. And the severity of the tethering is very important in the decision-making process. Again, we have been very aggressive. We have suggested in patients, of course, with severe tricuspid regurgitation, and this is a class 1 indication, symptomatic patient, but also, and this is the new thing about the 2012 guidelines, even in patients with mild, not only moderate, mild or moderate secondary tricuspid regurgitation, if the annulus is dilated, surgery to the tricuspid annulus should be carried out. And this is again is a 2A recommendation. So it's very important in this context to look at the annulus. We have here In the thoracic apical 4-chamber view in late diastole, we have to measure the annulus here. If this is more than 4 centimeter, that is to say 21 millimeter per square meter, that surgery is indicated even if tricuspid regurgitation is only mild. In surgery, this was alluded before by Robert, here you can measure with your fingers and with the meter like that, you can measure the distance between the two commissures here, between the septal and anterior and posterior, and this is more than 7. You have to consider this a dilated annulus, and even if a tricuspid regurgitation is not there, you should do something to the tricuspid annulus. And the reason is that Gilles Dreyfus found that in patients who did not receive concomitant tricuspid annuloplasty, progression of none or mild tricuspid regurgitation to 3 or 4 plus occurred in 34% of the cases. You see here the grade 3 or 4, the group of patients who did not receive tricuspid annuloplasty, you see the progression of the disease, which is not seen in patients who have been treated also with a tricuspid valvuloplasty. This is the paper was already presented by Robert. It's an important paper from Leiden. Tricuspid annuloplasty prevents right ventricular dilatation and progression in patients with tricuspid annular dilatation undergoing mitral valve surgery, and this procedure is recommended even if there is no tricuspid regurgitation. We have a randomized study that was carried out in Rome, Italy, by the group of Riccardo Sinatra, and the prophylactic tricuspid annuloplasty, this was the conclusion in patients with dilated tricuspid annulus undergoing mitral valve surgery, did not add operate risk, and it was associated with reduced rate of tricuspid regurgitation progression and a beta echocardiographic and clinical outcome. This was a prospective randomized study, so really these data are quite convincing. And look at here, these are data from the Cleveland Clinic again, the preoperative tricuspid regurgitation 2+, patients who have been treated. You see the tricuspid regurgitation grade, the great majority did not had only the 0 or 1 tricuspid regurgitation. In patients in whom tricuspid regurgitation was not treated, the degree of tricuspid regurgitation was higher. So this is really suggesting the necessity of being quite aggressive with tricuspid regurgitation. Now let's go to the third clinical scenarios. It's late tricuspid regurgitation following left-sided valve surgery. These patients present many years after initial surgery. They present sometimes with hydrothorax, ascites, venous congestion. They do very poorly. They are in heart failure. They require repeated hospitalization, and this certainly is a very difficult problem. Certainly, late mortality after mitral valve surgery is strictly related to the presence of significant tricuspid regurgitation, and this has been very well demonstrated in several papers. These are 2 papers dealing with this problem. So it is quite logical from this respect to take care of this late tricuspid regurgitation. But what is the problem? The hospital mortality for late tricuspid regurgitation. Look here, I just choose some of the papers dealing with this problem. Look at the hospital mortality, 25%, 16%, 20%, 8%. You know, it's really a very, very high hospital mortality we have to deal with. So we have to be very careful to do surgery under these circumstances. Look here, these are old papers, but to tell you what are the late survival after surgery for tricuspid regurgitation following mitral valve replacement or repair. This is in this clinical scenario. You see here at 5 years, survival only 31%. At 5 years, survival of 41%. This is our old papers. But look here, more recent paper. This is from Patrick McCarthy, which was published in 2004. And you see that survival after surgery for late tricuspid regurgitation, only 19% at 3 years. It's absolutely unbelievable, the results that can be associated with this terrible situation. This is the Tyrone David paper, which was already presented by Robert. You see here the surgical mortality is about 13%, but look here at the survival. Survival really is going down to about 50% at 10 years. So really long-term results are really quite disappointing. You see here another paper from the Leipzig group of Frederick Moore. The 30-day mortality, you see the overall 30-day mortality was 14%, was about 15%, was very similar to the Tyrone David group. And these authors concluded that the redo surgery, when indicated, should be performed sooner rather than later. Of course, we have to be very aggressive in this type of surgery when severe tricuspid regurgitation is present. In this particular clinical context, determinants of surgical outcome in patients with isolated tricuspid regurgitation have been investigated in this South Korea group, and they have seen that there are some factors affecting the results of surgery under these circumstances. Right ventricular and systolic area is very important. So the dilatation, in other words, of the right ventricle, particularly in systole, is very important in determining the poor prognosis. Look at here the hemoglobin. Hemoglobin actually in these circumstances is reflecting the status of the liver. So it's very right what Robert said before. If the liver function is very poor, then probably we don't have to approach this patient. You see here the difference according to the hemoglobin level. Of course, the clinical status of the patient is important. New York Heart Association class 1 or 2. This is a reason to approach this problem early in the stage of the disease. And when we have class 3 or 4, look at the results, which are much poor. And then, of course, there are other indicators, right ventricular fraction, area change, and so on, that can be very important in determining the prognosis of this patient. Now, for this particular group of patients with late tricuspid regurgitation, earlier surgical time is recommended. In the previous 2007 guidelines, severe tricuspid regurgitation and symptoms were recommended. And this was probably leading to a very late surgery. In the present guidelines, 2012, we have symptoms or right ventricular dilatation or dysfunction. So symptoms are not really, very severe symptoms at least, are not really a prerequisite to recommend surgery in this context. This is pulmonary hypertension, a contraindication in the previous guidelines, and this really I don't agree too much with what Robert said, is systolic pulmonary artery pressure. Of course, in these guidelines, the emphasis was put not so much on pressure, but on pulmonary vascular disease, on the presence of pulmonary vascular disease, because as you see here, if the cardiac output is falling, of course, the resistance can be very high, and we can have low pulmonary artery pressure, but very high pulmonary vascular resistance and pulmonary vascular disease. So we can have inoperable patients with normal systolic pulmonary artery pressure because we have a low output state and stage of pulmonary disease. So let's come to the point. Late tricuspid regurgitation should be prevented by addressing more aggressively and effectively the tricuspid valve during the primary mitral valve operation. This is an important point to take into account. You recognize this is the famous classical paper now of the Cleveland Clinic that showing very well the deterioration in difference, of course, according to the different rings, and so there's something difference between procedure and procedure. You saw that deterioration is more in the K and the Vega, in the sutural annuloplasty, a little bit less with this, but altogether is a kind of progressive deterioration. So current results of tricuspid annuloplasty are quite suboptimal. We have to use what we consider the best type of procedure for tricuspid regurgitation. Then we have enough data to tell that when tricuspid regurgitation is due to annular dilatation alone, annuloplasty is important. But remodeling annuloplasty with a semi-rigid ring is associated with the most durable results. We have several papers, several studies demonstrated that. So if the annulus dilatation is dead, we think that probably a prosthetic ring should be advisable. There are now new remodeling rings. I don't have a particular experience with one instead of another. These are three-dimensional configurations. They are advantage with one or another, but the point is that they are all prosthetic rings aiming at the remodeling of the annulus. I designed a ring which I thought that was a very, very useful, because since in functional tricuspid regurgitation, your regurgitation is mainly centrally located, then a ring like that, pushing the three leaflets and trying to force the coaptation point centrally, I thought that was a very good idea, but actually that was not considered by the industry, so this ring was left apart, and that was never came to a conclusion. But the concept itself, I think, was a good something, and we had a very positive data on the bench with functional tricuspid regurgitation created in a pig model just with a retraction of papillary muscles. Now, when in association to annular dilatation, we had significant leaflet tethering because the right ventricle is dilated and the papillary muscles are dislocated. Certainly, an annuloplasty is not enough. And in this patient, you see, has been very well recognized when the coaptation depth is more than 1 centimeter. The conclusion also of this paper is patients with exencephaly that they require additional maneuvers to ensure valve competence, additional maneuvers beside annuloplasty. And this is the additional maneuvers that can be proposed, tricuspid leaflet augmentation. So this is certainly, I agree 100% with Robert on this. In this particular case, this is something that has to be done. And this is the Clover technique, which also can be very effectively used in this situation. So we have a series now of more than 120 patients treated in this way. The Clover technique has very precise indication when annuloplasty is not enough. Annuloplasty is not enough when you have severe tethering. This is one situation. Or when you have, for instance, prolapse, like chordal rupture after trauma, or we have a myxomatous prolapse of the tricuspid valve, then annuloplasty is not enough. You have to use something else. So this is the good indication for the Clover technique. I don't know if the Clover technique, Pedro, can be helpful when you have this fibrous retraction. I really don't know, and I don't have experience in children. Certainly, when you approximate this, you also pull the papillary muscle together, and maybe can probably an easier solution to the very important problem that you mentioned before. How to improve overall results in patients with tricuspid regurgitation? Lower the threshold for repair. We have already seen this point. Improve annuloplasty device and surgical techniques. Augmentation of the leaflets, the Clover technique, the annuloplasty with rings instead of suture. Maybe these are some of these points. And then find new solution for high-risk patients. And this is, I would like to mention the first attempts of a transcatheter tricuspid annuloplasty. A kind of pragmatic approach is intended to replicate a proven surgical procedure, the K technique of bicuspid addition in percutaneous intervention. I think that Robert was showing that Larry-Cohn experience is showing very good results with the K annuloplasty, almost similar to the ring annuloplasty. Am I wrong with that? No, I think that is and so the K technique, if properly done, can be a very good solution to this. So a kind of device was designed. This is mainly the work of Francesco Maisano in our institution when he was working in Milano, together with many of my young co-workers. It was the device is including an anchor to be put in this particular situation, and the catheter here going into the inferior vena cava. In the inferior vena cava, a stent is placed, and then the whole thing is pulled back in such a way to create a bicuspid, tricuspid valve. And several experiments in the animal lab have been carried out. The implant design has been completed. Also the delivery system, everything was completed. We had 40 acute successfully implant, and with the 20 chronic animal up to 90 days. So there was a quite large experimental work behind this work. And you see here in the animal, it looks to work quite well. The anchor was put. I was assisting many times to this type of experiments, and was surprisingly easy because you could put the anchor more or less at the commissure between the anterior leaflet and the posterior leaflet, and then put your stent in the inferior vena cava, and you could pull. You could see very well the reduction of the annulus, and also you could see a beta approximation and an increase in coaptation length. So I would say, and then the latest experiment look a very good healing of the anchors in that place. So we were very, very optimistic. But what happened? We did actually the first in man in the fourth trimester of the 2013, and we additionally did 2 cases, so a total of 3 human experiments. And I was hoping to bring you the very satisfactory the results, but unfortunately, for one reason or another, this kind of system didn't work. Nothing happens to the patient because, of course, the patients are well, but we have been unsuccessful for one reason or another, for the not proper imaging, for the angle, which is very much different from the animal. So, also for the fact that the anchor was not deep enough and it could not capture properly. So the design at the moment is under readjustment, I would say, and I hope that in the short time the human experience could continue. Fortunately, these 3 patients are all well. One of them has been, three of them, all of them have been operated, and they are all well. But it's a pity I couldn't give you the results connected with this human experience. Thank you.
Ottavio, thank you so much for this fascinating information we are receiving. Questions and comments? Professor Boccheria.
Yes. When you're making this new Alfieri stitch for tricuspid, I don't know how do you name it?
The Clover, because it's like
just sorry for that.
Trifolium.
How do you name it?
Clover means trifolium.
Okay, thank you. How do you measure the sizes which left? Do you measure? Do you want to know?
Absolutely, there's no need. The tricuspid annulus is gigantic in this situation.
I'm interested.
Yeah, you look exactly.
For example, I'm a relative of the patient. Okay, I want to know.
You look exactly at the central point of each leaflet. And you put one stitch there, one stitch in the central point, one stitch in the central point of the septum, and then they put them together. That's all.
Yeah. The reason I'm asking, sometimes we do different stitches and so. And at all time I try to measure it by Bush, it's it's a special form, and you can measure all those. So I think that maybe it might be reasonable just to measure if
to measure with the Hager's later.
Each one, yeah.
Okay,
and then you have,
you can do, but really the stenosis has never been a problem. It's a really gigantic orifice, and the extension of the edge-to-edge suture is very limited. It's just one stitch centrally, so you have 3 huge orifices.
Oh, I mean that if you measured, you might have even some annuloplasty just to keep.
Yeah, also, of course, you can use annuloplasty, but there's no problem of tricuspid stenosis.
Thank you,
Pedro, please.
Ottavio, that was fantastic. I love the creativity. I'm wondering whether there is some degree of pulling of that papillary that has to occur when you bring all those 3 leaflets together. Because in essence, the septal leaflet is very much attached to the septum. And so you're bringing that anterior leaflet and that inferior leaflet towards that septum. And I'm wondering whether you're accomplishing the same thing in a much simpler way. And I'm wondering if you're looking at this sphericity in your patients after this kind of procedure late, and whether that would be something to really accomplish.
What I can tell you in the population that we have been treating, which is certainly different from the pediatric population, we have been looking at the ventricle, we have been looking at the results, we have been looking at recurrence of tricuspid regurgitation, and results have been really, really good. They have been published by the first author is Elisabetta Lapenna, and she published, I think, about 70 cases with this, and you can look at the Journal of Heart Valve Disease, and the results are really very, very good. And now we have more than 150 cases, so I think we should look at them. But again, I think that in congenital surgery, maybe you have some more different situation. Probably it's part of a congenital anomaly, the fibrosis and retraction, and the papillary muscle is not only dislocated by the dilatation of the ventricle, but is itself fibrotic and retracted. Is that the case?
Well, certainly in Epstein's that's the case.
Yeah.
But in many of the others, because we see functional tricuspid regurgitation also because many times our right ventricle is a systemic right ventricle or is under very high pressures. But I think what we've learned is that getting the valve leaflets or the valve annulus reduced by itself is not enough. It gives you a competent valve in the operating theater, but a few years later, the right ventricle is still a balloon, and now you have even more regurgitation.
I think that is a very important concept. You know, we have to look at the tethering. If the tethering is there, we have to be sure that the ring per se is not going to be long-lasting.
Yeah, exactly.